tremendous opportunities to enhance staffing and services. The residential redesign paradigm was designed to allow providers flexibility, and the regulations are much less prescriptive. Our focus is on good clinical practice and services that are participant-driven, trauma-informed, strength-based, and recovery-oriented. The application exercise was designed to elicit your clinical vision of how services will be provided. It should not be written by a grant writer, but should include information from a transdisciplinary team. What are you doing? When are you doing it? How are you doing it? And who will be providing the service within your agency? Brenda?
Hi. Good morning, everyone. This is Brenda Harris-Collins. And today, as we begin the webinar, we want you to begin to understand that OASIS hopes to have a success-oriented application process and has developed several tools to support programs as you consider which elements best meet the needs of current and future service recipients. Programs may apply for any or all of the elements. The elements are stabilization, rehabilitation, and reintegration. We want you to support the successful transition to Part 820. OASIS, in conjunction with the Clinical Advisory Group, developed a self-assessment tool. And prior to submitting the Part 820 application, we're encouraging all providers to utilize this tool. The Part 820 Readiness Assessment document and other provider support tools may be found on the OASIS website. This particular document is intended to facilitate OASIS-certified residential programs in their discussions as they evaluate strategies towards implementation of elements of the residential model. Ongoing learning communities and collaboratives are also available to facilitate program dialogue, and for more information, we direct you to mctac.info@nyu.edu. Also, there is another source of information, resource available to you, and that's your field office coordinators. They are available, and you should be engaged with them for development of budgeting and exploration of startup funds surrounding implementation of Part 820 programming. You will find the complete Part 820 designation application is located on the OASIS website. You go to the OASIS website, you click on OASIS Services, and then click on Certification, and the first thing up that you will see is the Residential Redesign application. This webinar will explore the strategies required to complete a successful designation application. It will not speak to funding or Medicaid managed care contracting. So now we're going to begin our first section, which we'll talk about and begin talking to you about general instructions for residential redesign by section. Our sections include Section 1, which is applicant information, Section 2, project narrative, Section 3, staffing, Section 4, attestation, and again, you see we have the website located where you can find that application, and the following slides will walk you through the actual application and the required as well as preferred components. Section 1 is identification of applicants. When you look at the application, the first section of this residential redesign conversion application is the entity administrative headquarters mailing address. And we're asking you to enter the information exactly as it appears on your operating certificate for the program you are requesting to be designated. We also are asking for the application contact person, name of the contact person, their telephone number, email address, and also we're asking that when it asks for the address, that you enter the full site address. The next section is the conversion site. And here, this particular site, this will really look at the program address where the services will be provided, the conversion site, where is your PRU, where is it located, and that's the address that you will provide. On the operating certificate, your specific designation will be noted once the application has been approved. The application is connected to the specific PRU. Therefore, if you have multiple PRUs, you will submit an application and identify the element for each PRU for which you are applying. One of the things that is on the current application that is not there that we have on the slide, you will see that we indicated on the slide number of beds. So we're asking that you will put on your application the number of beds, as it will assist us in reviewing your application. The application is in the process of being reformatted, and we want you to realize that when you see the reformatted application, that will be one of the elements that you will see. We're also asking that you will make a copy of your operating certificate for that PRU and attach it to the application. Henry?
Okay, so we're talking about the proposal narrative here. This is your vision, the goals, the mission of your agency. So in your agency, what will the element you're applying for look like? In Henry House, stabilization will house residents with rehabilitation. We believe participants heal in community and will utilize the participants in rehabilitation to model and support those in stabilization. Brenda's agency has a different vision.
We have a discrete dorm for stabilization in Brenda's agency. So what is your agency going to look like? How will it look for you?
Right. Okay, so attachment 1 speaks to your proposal narrative, so clearly delineate which key concepts you're addressing in your narrative by numbering them appropriately and being as succinct in your response as possible. For the reviewers to be able to follow along in your narrative, just simply number the concept that you're actually speaking to. So the applicant will demonstrate the ability to integrate the following key concepts: promote recovery from substances and move individuals through care based on attainment of goals identified in an individualized treatment plan. Shift from program-driven to participant-driven assessment, treatment planning, and service delivery. All right. This may require a shift in thinking from linear movement in phases of treatment to more individualized movement based on achievement of individual milestones. Some participants will move from stabilization to outpatient services and home-based recovery support services. Others may require rehabilitation and reintegration services. So unlike the way we've been delivering services previously where there was a very linear movement, this one is very individualized. Treatment planning and decision making is based on an assessment of individual risk, resources, values, and preferences. In recently reviewing an application, the provider actually demonstrated how participants in their agency would identify their individual preferences. In order to capture personal preferences, the provider asked residents to prioritize what I want from treatment. And then they set up a sheet where the resident would be able to identify in a survey format, something like, I would like help with problems with my marriage, rate that 1 to 3. I would like help with depression and moodiness, rate that 1 to 3. I want to take Suboxone. And once having developed that, they now had a format to actually articulate an individualized treatment plan that demonstrated the participants' preferences. 4, empowerment and individuals of family and recovery is strength-based and success-oriented. So here we're looking for providers to define a menu of services that offer choice. Service duration is based on an individual milestones versus a program length of stay that are individualized and geared towards movement to increasing independence. In reviewing another recent application, we found that the provider had identified specific assessment tools that they would need to create baseline assessments to demonstrate what the individual markers would be to move residents from one element of care to another. What would be the social determinants of progress? Those admission assessments identified were, for instance, first and foremost, the locator. They had utilized MAST and DASS for alcohol and drug dependence, a modified mini, something to identify trauma, a post-traumatic stress disorder checklist, a PHQ depression list. They had COWS and CWA scores. They utilized a Texas Christian University motivation scale. That way they had a baseline, and when they got on the phone to speak to managed care companies, they could have objective accountability as to progress that the participants made during their stay in treatment. 6, medication-assisted treatment is available and offered to all participants as clinically indicated in each element. So medication-assisted treatment will require that staff be trained on the benefits and positive outcomes surrounding MAT and ancillary withdrawal services be addressed within the organization for a successful transition. Technical assistance actually is being offered by OASIS through Zoraida Diaz, who can be contacted at zoraidadiaz@oasis.newyork.gov, and you can use that as another resource in developing your applications as well. Brenda?
Okay, now we're going to actually walk through the elements, which you will be defining as a part of your proposal narrative. The first element is stabilization. Our definition of stabilization is that stabilization provides a safe environment in which a person may stabilize mild to moderate withdrawal symptoms, severe cravings, psychiatric and medical symptoms before referral or transition to another program or element of structured treatment recovery. Stabilization requires the supervision of a physician and clinical monitoring. It addresses immediate needs for medical and psychological intervention. It provides the environment for the education, induction, and monitoring for addiction medication where appropriate. It allows time to assess other ongoing needs, whether it be nutrition, wellness, vocational, housing. And it prepares a person for further treatment if needed by education on addiction, introducing the person to community living model, builds basic communication and coping skills. So it's important to understand that stabilization really incorporates all of those. Also to understand that many of our providers we know have already been providing this as a part of what they do, but it has not had the support that is needed, and this is an opportunity to support that. One of the steps when we're looking at this, when you're submitting for stabilization, is that a protocol for ancillary withdrawal for each substance for which the program will provide in this service must be given. And you can find additional information can be found on the OASIS website regarding protocols for ancillary withdrawal service. The second thing that you're going to put in your proposal narrative is a description of the services that will be offered. Each agency will be required to develop a vision of what this element of care will look like and the services to be provided. The third thing is a description of the assessment process, including time frames and staff responsible. This description should meet regulations surrounding admission, medical assessments, assignment to primary counselor. Then we're looking for a sample treatment plan for resident and stabilization, including goals for completion of stabilization. The sample treatment plan demonstrates not only services provided, but also should include individual goals and objectives, milestones to determine completion of stabilization. The fifth item that you're going to put in your proposal narrative is metrics for evaluation of this element. And I think that Henry spoke real briefly about, defining what those markers are and looking at those markers and how you will define and look at resident engagement, resident retention, the population or aggregate measures of specific goal attainment. How will these things be measured? So each agency will need to describe in this element of care what is it that you will be using as your markers around engagement, retention. For this stabilization, you may look at decreased cravings for a percentage of participants utilizing medication-assisted treatment. It is important to understand that, especially because this particular phase, when you look at ancillary withdrawal services, staffing for this element, which will be further explored, will include medical personnel, mental health, clinical and milieu staff that will provide intensive engagement services to reduce the cravings and engage participants in a treatment process. Henry?
Rehabilitation provides a structured environment for persons whose potential for independent living is seriously limited due to significant functional impairment, including social, employment, cognitive, and the ability to follow social norms that requires restructuring social supports and behaviors in order to develop sufficient skills. These participants require a course of rehabilitative services in a structured environment with staffing to provide monitoring, support, and case management. Rehabilitation provides clinical and medical services, individual, group, and family counseling as appropriate. The rehabilitative focus is on improving life, vocational, daily living, and other skills. Increased use of program community to practically apply learned skills, identification and connection with outside community resources. So the rehabilitative element will assist individuals to develop pro-social communication skills. Counseling will address emotional regulation, mental health symptom management. Case management should be provided to link participants to housing and other community resources. So in rehabilitation, in your application, you're going to describe the services that will be offered. Do you have specialized tracks, for instance, for LGBTQ populations? Do you have tracks for trauma survivors? Do you have a criminal justice track? What kind of groups are you providing? In stabilization, you may have had more one-to-one counseling sessions because of the enhanced staffing patterns. What will that one-to-one counseling look like in rehabilitation? What will the group process look like? There needs to be a description of the assessment process, including time frames and staff responsible. This description should meet Part 820 regulations surrounding criteria and time frames for medical assessment, psych assessment, and assignment to primary counselors. A treatment plan for the resident in rehabilitation. What would the goals for rehabilitation look like for completion of that element? Demonstrate treatment plan utilizing objective measurements that you will be able to articulate to Medicaid managed care companies. You must describe how you'll evaluate your agency's success in this element of care. Again, Did you reduce maladaptive behaviors? Did you reduce cravings? Did you increase prosocial behavior? And how is that going to be measured and demonstrated?
Now, we're going to look at reintegration, the third element. And this element provides a community living experience in either congregate or scatter site settings with limited supervision and/or case management. Persons appropriate for these services are transitioning to long-term recovery from substance use disorder and independent living in the community. Reintegration in a congregate setting or scatter site setting will provide opportunities to actualize skills learned in treatment in the community, linkages to community services and resources, services for those transitioning to long-term recovery and independent living. And the key to this element are the logistics involved in providing the services for individuals as close to their communities of origin. So this is a big part of residential redesign and really looking at how we're providing those reintegration services and that they are in areas close to the community of origin. For example, if you have residents from Syracuse, New York, their reintegration should not be perhaps in Queens, New York. They have family, their children are in Syracuse, and many times we're connecting them to community resources that cannot be sustained where they go in their community. So it's important that this be taken into consideration when you begin to look at applying for reintegration. Participants should be able to transition to stable housing and employment in reintegration. They should have access to services within the agency and linkages to services provided in the community. The case managers should be connecting the participant to housing and recovery supports in the community, where they would develop reentry skills, actualize connection with identified community resources, and that person will practice the skills learned in the outside community while continuing to support via the program community. We know that a person their recovery really happens where they live and in the community that they live. That's where the recovery takes place.
Great. So attachment 2 demonstrates successful, relevant experience. Describe your experience delivering treatment services that utilize best and promising practices that are appropriate to the element you are applying for. So what specific promising practice connects to stabilization, rehabilitation, or reintegration? Providers should describe experience delivering services to an identified demographic and the evidence-based and promising practices that they will utilize in the specific element they are applying for. Utilization of trauma-informed practices, for example, to better inform interventions in the rehabilitation element to address maladaptive behaviors, or the utilization of motivational interviewing to better engage and identify participant-centered individual treatment plan goals in stabilization. Utilization of seeking safety or the sanctuary model with staff and residents to create safety within the facility for individual and community healing to occur. So you're giving us concrete examples of which evidence-based practices you're utilizing and what the goals of those practices are and their connection to that particular element of care you're applying for. Describe your experience delivering and your understanding of the integration of SUD services with mental health, physical health services. For example, services for chronic health issues, pain management, co-occurring disorders. Providers should describe a transdisciplinary team approach to participant services and strategies. Providers will be addressing their ability to provide care coordination in Attachment 2.
Attachment 3 of the application looks at organizational capacity. It's asking you to describe how your agency's infrastructure, the physical setting, organizational managerial staffing, staff development will support the implementation of each of the proposed elements and explain how each element fits into your agency's mission. The provider should describe an organizational infrastructure that demonstrates staff development and specific training that will support the element of care, as well as how the vision and mission of the agency supports that element. Provider will describe how they plan for the integration of applied elements even into their physical plan. And for many agencies, this is something that has come up and we've talked about on numerous times, how that physical plan will look. For example, looking how will you implement stabilization, let's say? Will you have a separate floor for stabilization and separate staff, or will they coexist along with rehabilitation on the same floor? Because your philosophy of your agency is that you have those peers who have had some time in recovery. They can really show a person that recovery is real and kind of help them through the process because they've been there, and they can, kind of help that person through the stabilization process. So what is it going to look like for your agency? But it also, and it's critical that it's tied to your vision and mission of the agency and that it supports that element. The second thing is to describe the organizational capacity to collaborate with other community stakeholders, treatment service providers, and managed care plans. Identify the service providers with whom you have developed linkages with, and include MOUs to demonstrate the linkages for the provision of specialized services. In residential redesign, one of the primary goals is for the provision of service matching. This is really important that individuals come to a place that they can that will meet their needs, that they have the specialized services that may be needed. When providers identify specific services they cannot provide the participant, they should show linkages to those services within the community. For example, a person comes in and they have an eating disorder. We have typically said we take everybody. So this is an opportunity to really look at what is it that you're going to provide, who are the persons that you work best with, that you yield the best outcomes with. If you don't have the services to provide someone who has an addiction along with an eating disorder addiction, substance use addiction along with the eating disorder, then do you have the linkage to support that person? Do you have staff that understand that and will be able to support that individual? It's time that many times we've taken individuals that we cannot really help, and then we wind up having problems in the facility because they do not kind of fit what it is that you need. But you need to look at how your organization will handle that. The third thing is to attach a residential redesign personnel qualification worksheet for each element you are applying for, and the proposed treatment services provided for each key staff position. Attach a job description of the qualifications and experience that will be required. Demonstrate how your staffing for the proposed services meets the element required. Indicate how many qualified health professionals and/or non-credential staff that will be working in the element. And we want you to attach an organizational chart specific to that PRU. Personnel qualification worksheet and staffing will be further explored in this webinar. Your workforce should possess experience and skills that correlate to the services provided in the element.
So Brenda just said attach an organizational chart specific to the PRU. So in the application, we don't require your agency organizational chart. That's of no use to the reviewers. What we're actually looking for is who's going to be working in the elements of care that you're applying for. So in the original application, as it's posted right now, this says attachment number 4. It is no longer an attachment. We've been listening to the providers who kind of called in and have told us that we were being repetitive in what we were requesting, so we're taking all of that into account. We appreciate your feedback, and these are program approaches and service required components, not an attachment. So the first required component is identify how you'll target the element of care to specific participant needs. Providers will need to identify what assessment tools or instruments they will utilize in order to clarify participant-centered, strength-based, trauma-informed, recovery-oriented care that's specific to the participant's needs. 2, list and define the specific services to be offered within the element. What assessment, what specialized groups, what specialized services will be utilized, will be provided in the element for which you're applying for. 3, discharge planning must begin at admission and address the wide range of concerns that affect the participant. Examples: physical health, mental health, family issues, housing. So participants are linked to services within their communities to support long-term recovery. Discharge planning is a key component. It's a cornerstone of the work that you're doing and should be addressed in each element. You know, we've always said that discharge planning starts when the individual comes into treatment, but if we take a look at our lengths of stays, it's actually been implemented in later stages of treatment. 4, medication-assisted treatment must be available and offered to all participants as indicated in each element, and staff must be thoroughly trained on uses of addiction medicine and its relation to long-term recovery. Once the staff are thoroughly trained, they will have the ability to counsel and support residents who require the services of medication treatment or ancillary withdrawal. 5, the agency providers must have a capacity to interface with Medicaid managed care companies and submit claims. We're asking you to describe a plan to bill and communicate with plan staff. So the agency needs to have a strategy as to how and who will be assigned to communicate with managed care companies. Some agencies may have all staff trained to provide these services, and others will assign key point people to do that work. 6 asks you to describe your experience delivering treatment services that utilize best and promising practices that are appropriate to each of the elements you're applying for: stabilization, rehabilitation, and reintegration. And 7 asks you to describe your experience with integration of SUD services. We've already spoken to 6 and 7 in attachment 2. But these are required components in your application. The preferred components are?
Okay, so these are preferred components. So preferred and differing from required components, these are components that you really should take a look at in your move to transform your system of care. They are important components, just as much as the required components. But as you develop, these are some of the things that we want you to consider. The first thing is that the provider should show ability to provide meaningful care coordination, either with its own staff or through work with health homes or other care management agencies. As this whole system is changing, these are things that you will not be able to ignore, and you should begin to look at how you can work with health homes and other care management agencies if you do not have care coordination yourself. And we know some of our providers do all of that. The second part is clinical supervision. Clinical supervision should be provided by staff with appropriate levels of training and education and with demonstrated experience in delivering chemical dependency treatment services for each element of care for which the program applied. The provider should show how it would develop and implement a comprehensive in-service training curriculum and engage in appropriate workforce supervision. Clinical supervision is the cornerstone of quality treatment services and ensures fidelity to evidence and promising practices, as well as provide the support necessary for the paradigm shift occurring with residential redesign. Regular clinical supervision has been shown to improve outcomes for both staff, retention, and participant engagement. When we began to do some of the forums, we talked about how clinical supervision is so important that it's something that needs to take place on a regular basis. You need to look at who's providing the supervision and make sure that they have the skills to help move your agency along. The third thing is providers should demonstrate through documented staff training and case review systems the ability to address co-occurring mental health and substance use disorders, as well as integration of physical health with behavioral health concerns, either within its own program or by partnerships with agencies. Psychiatric and physical evaluation needs to begin with the intake evaluation process. Residential redesign provides for staffing patterns that include healthcare professionals, doctors, psychiatrists, psychiatric nurse practitioners, RNs, LPNs. Existing staff should be trained to interface in a transdisciplinary team approach, recognizing and breaking down silos to achieve better outcomes. Staff training to provide integrated care concepts is going to be extremely important. Fourth thing of the preferred components is the provider should demonstrate the ability to provide person-centered services for individuals who need ongoing support to seek, obtain, and maintain employment. Employment support services should be included in the initial assessment and admission process and continue throughout treatment and beyond as ongoing support of a long-term recovery plan. Early engagement surrounding employment, vocational training have shown to retain the individuals in the treatment process. These are the preferred components, and Henry will continue to talk about some more.
Providers should demonstrate a clear understanding of trauma-informed, person-centered care and recovery-oriented systems of care, and utilize processes to obtain regular feedback from participants on the quality of services provided. The provider should be able to demonstrate the use of peer-based recovery services as part of the participant long-term recovery plan. This asks you to describe several preferred components, one being trauma-informed. The other component speaks to obtaining regular feedback from participants. Most of the agencies that we've talked to already have an existing feedback loop, so you don't have to reinvent the wheel, just articulate what you presently have in place or how you might enhance that. The third speaks to a demonstration of the integration of milieu-based recovery services, how you'd work with recovery coaches, how you'd utilize milieu staff to support the clinical activities within your facility. 6 speaks to providers should demonstrate the ability to provide family-based services and address the impact of addiction on family systems, including family issues for those who are involved with the child welfare system. The provider should demonstrate the ability to provide family-based services or linkages to those services as needed. With the enriched staffing pattern, having the ability to provide enhanced family counseling and support services or the linkages to those services are integral. 7, you should demonstrate through documented policies and procedures the daily operations as per the 820 regulations. We are not asking you to reinvent again. Revamp the current policies and procedures. Policies need to reflect the day-to-day operations of the element of care. Stabilization procedures surrounding supervision and monitoring of participants will reflect the intensity of that care, more individualized counseling versus group. Rehabilitation policies and procedures will address the requirements of the population that you're serving there.
Now, we're moving on, and those required and preferred components, there are now another attachment that you will have, and it will be program effectiveness. And program effectiveness you will explain how you will use the data to determine program effectiveness and to make improvements in program practices. In developing your application, you have been asked to identify metrics when we talked about stabilization, rehabilitation, and reintegration. We talked about identifying metrics for evaluation in each element. And we want you to demonstrate the utilization of UR and QA data and information and its impact on modification of program practices. The fifth attachment will be facility compliance. Facilities must comply with the current Part 814 general facility requirements, including all federal, state, and local code requirements. If necessary, attach the program's plan for bringing the facility into compliance. I'm going to turn it over to Henry, and he is going to talk about the third section.
Section 3 speaks to staffing. This is what providers have been asking for many, many years, an enhanced staffing pattern that could treat the myriad of needs of the participants we serve. You have been valiantly attempting to stabilize participants with little to no medical or mental health staff. How much burden will be alleviated from your clinical staff when you don't have to monitor medication but have an LPN or an RN on your staff to provide that service? Yes, this transition is an opportunity to enhance staffing. Providers should confer with OASIS Field Office for assistance in the development of budgets to meet staffing requirements and the elements they applied for. The field office staff will also have the ability to speak to providers about startup funds that will be available to be utilized. So, staffing patterns for residential redesign elements. This is applicable for all Part 820s. A residential program of 10 beds or more should have a full-time director who's a QHP and have 5 years of full-time experience. A residential program with fewer should have a part-time director who's a QHP and should have 5 years of full-time work experience. A residential service should have a clinical supervisor who's a QHP with at least 3 years of clinical experience, and a residential service should have a qualified individual designated as a healthcare coordinator. What's really key to all of the elements that we're describing to you is that staffing can be shared between stabilization, rehabilitation, and the reintegration elements. As we explore the specific staffing for each element, what we need you to identify is how much time you envision that particular staff would be working in that element you're applying for.
So the staffing applicable to stabilization, those staffing requirements include registered nurse on site daily, LPN available on site daily including weekends, a medical director that possesses a Federal Data 2000 waiver. Proposal must identify how the program will evaluate sufficiency of medical director time and make adjustments. All residents in stabilization who are in need of assessment for withdrawal or medication-assisted treatment must be seen by the physician. There must be an on-call physician for stabilization. Psychiatrist and or psychiatric nurse practitioner is required staff to evaluate all residents who have a history of mental health disorder or who are exhibiting symptoms. The program must identify how it will also evaluate the sufficiency of psychiatric time and make adjustments as needed to increase or decrease that time. A LMSW or LCSW or LMHC or family therapist in sufficient numbers are required to provide regularly scheduled psychotherapy to all residents who are in need of such services. and we're asking you to look at the clinical standards document for guidance on assurance sufficient staffing pattern. CASACs in sufficient numbers to serve as the primary counselor, at least one CASAC available at all times. Milieu staff, all shifts in sufficient numbers available at all times. 2 staff per overnight shift, one of which must be a CASAC or clinical staff member as defined in Part 800. And we know that there has been a lot of conversation about the 2 overnight staff. And the intent here is to have somebody in the facility that can deal with crisis instead of an overnight watchman. These are individuals who many times do not have the skills to intervene during a crisis. And so we really want you to look at that and look at, again, I'm going to read that because it says 2 staff per overnight shift, one must be a CASAC or clinical staff member as defined in Part 800. Vocational counselor is also required and case manager.
Okay. So staffing requirements for rehabilitation, you've got a registered nurse on site daily, an LPN on site daily including weekends, a medical director that possesses a federal Data 2000 waiver. The medical director may serve as medical director of more than one program certified by the office. Okay, so he's not just locked into that particular PRU. Psychiatrists and or psychiatric nurse practitioners to evaluate all residents that have a history of mental health disorder, LMSW, LMHC or family therapist in sufficient numbers to provide psychotherapy, CASAC in sufficient numbers to serve as primary counselors, milieu staff, all shifts in sufficient numbers. And again, the program will identify how it's going to evaluate the sufficiency of staff to participant ratios. There's no regulation surrounding that, so that's your best clinical judgment, but you've got to give us some kind of rationale of how you'll evaluate it and make adjustments as needs increase or decrease.
And let me just say, for example, when stabilization, it's going to reflect the need for one-on-one engagement necessary to engage participants in the recovery process. So you're going to look at it in that sense. The next thing is staffing applicable to reintegration. And this is looking at staffing requirements for congregate care settings and staffing requirements for scattered site settings. The staffing requirements for congregate care settings is a registered nurse, LPN for medication monitoring, clinical staff in sufficient numbers to provide care coordination, milieu staff in sufficient numbers to facilitate activities of daily living, community meetings, and engagement of residents in recovery skills building, vocational counselor, and case manager. Remember, there is an ability to share staff between elements. And the staffing requirements for scattered site settings is staffing to remain consistent with 819.9 and 819.10 regulations, and a reintegration element in scattered sites should provide linkages to services within the community to meet the needs of participants. Henry?
Great. Okay, we're on the home stretch now, people. I know this is dry stuff, but we're walking you through it point by point so that you have a successful outcome in your application process. So these are the instructions for the personal qualification sheet, right? And the very next slide actually is the personal qualification sheet. So you're going to be entering the employee name, title, or position, including the medical director, program director, clinical supervisor. You've got examples as to how to do that. a number of weekly hours dedicated to that operating certificate, enter the number of employees' weekly hours that they'll be dedicated to that particular element of care when you're handing in this qualification sheet. There's a work schedule that we're looking for, enter the employee's typical work schedule. We've had several providers, and I think this is a much better way of doing it, who did their application and gave us a separate, I'll just move to that. Wait a second. Boom. Nope, we're going the wrong direction. I'll go back here. A separate sheet for staffing, and that looked somewhat like that. It's really not. Which kind of identifies for you Monday through Sunday where the staff is and what hours they're working. That makes it very clear for you, demonstrates what the coverage will look like. We're also looking for education, enter the highest degree obtained on the highest grade completed, whether the person has an MSW, a GED, an associate's degree. There are some questions about experience. List general experience and training in chemical dependency services. Identify training and or experience which meets Part 820. So we want pertinent experience in chemical dependency services. Is it somehow connected to that particular element of care that the individual is going to be working in? We want you to identify QHPs. Enter the number of qualified health professionals or CASAC or CASAC trainees. We'd also like you to enter any kind of credentials those individuals have, whether it's a license or a credential number and the expiration date. So that would be very, very helpful to be able to see the personal qualifications as well as a work schedule. We're going to go into Section 4, which is attestations. Brenda?
Okay, so this is one of the last parts of your application, and it's the provider authorization for submission, and you'll have the authorized provider representative signature, their title, and the date. This must be signed and dated where indicated by the CEO, executive director, or if there is no such officer, a person authorized to act on behalf of the individuals or entity filing the application. If you are submitting the application electronically, the name typed in the space provided will be accepted as a person authorized to act on behalf of the provider and is attesting that all information provided in the form is accurate and true.
Wonderful.
Wow.
You are finally sending your application in. When you send your application in, we'd like to see it in triplicate as a hard copy. We'd also like to see an electronic version of that document. It should be addressed to the Bureau of Certification. Some of the hardest working people in the agency are working in the Bureau of Certification and System Management. That's a shout out to that great team. In review, we're looking for the organization's overall treatment philosophy, goals, objectives, and outcomes for each element of care. Provide the description for stabilization, rehabilitation, and reintegration. What services are offered in each element? What's the general staffing for each element? What's the clinical supervision, format, expectations, and outcomes? Again, I'd like to stress that this application process is designed to be success-oriented. We're looking forward to working with all of you guys collaboratively as providers to ensure that the people we serve receive the best treatment possible. And now we'll open it up to any questions in the chat room. or you could forward questions regarding to transition in the future to our Pick'em mailbox.
Hi, great. Thank you very much. This is Ileana Meltzer, and we'll now start the Q&A portion. We're just going to start scrolling through those things that have been received in the chat feature.
Okay. So the first question is, will participants in rehabilitation phase be able to receive services from a Part 822? And the answer to that question is no. The per diem rate captures the clinical services that will be provided in the rehabilitation phase. In reintegration, people can be seen in a Part 822 or for their clinical services. What medical services, in addition to addiction medication, will the plans expect to be provided directly? And that is, the way we've been answering that question is typically anything that is, related to doing a medical assessment or a physical to determine what the person's physical needs are should happen within the program. Triaging, all of the, if somebody went to see the doctor, for a sore throat, and that doctor had the ability to kind of assess the need for going off-site or not. Those are the kind of medical services that would be expected to be provided within the program. One of the things that we are expecting and anticipating having medical staff there will be to help patients be able to triage. So right now, you don't have any medical staff available. People sometimes are sent off-site to even an emergency room to be evaluated or to an Article 28. Sometimes that's necessary, and sometimes if you had medical staff available, they would be able to advise and help a person. So anything that is required by regulation, anything that is a normal course of triaging for medical concerns would be captured, and then all of the addiction and psychiatric care that are provided by regulation are incorporated into that per diem rate. Anything beyond that, we would expect that the person would receive medical care off-site, and it's not incorporated into the expectation of providing medical service. Okay, so if a program selects to apply for rehabilitation element, can the program still initiate an MAT if desired by the resident? And the answer to that is yes. The requirement for providing a withdrawal service, a stabilization and withdrawal service, applies specifically to the stabilization element. And anybody who would be coming into your program who needed that service probably is most appropriate for stabilization. However, somebody could come into rehabilitation who is already stable but has been perhaps struggling with some cravings while they were out in the community. They may have some recent use, but they're not in need of withdrawal services. You could initiate medication with that person to help them to deal with those symptoms. So medication, addiction medication is something that could be provided in the rehabilitation phase. Will participants in the rehabilitation phase be able to receive services from an 822? No, it's expected that those would be provided in the 820. Is there any prohibition regarding the use of outpatient treatment in addition to the residential treatment if during any of the three elements? In stabilization and rehabilitation, the first two elements of that are covered in the application, all clinical treatment for an FUD and for co-occurring mental health, in most cases, are expected to be provided within the 820. There would be, if somebody was already connected to a psychiatrist in the community, or if their mental health needs were so great that there needed to be something in addition, that wouldn't be prohibited. But for 822 services, it's inconsistent to be in stabilization or rehabilitation and have an open case in a Part 822. In reintegration, we would expect clinical services to happen in a Part 822, but all the person's clinical services should begin to start happening or transitioning at least to the community at that point. Is there, are there suggestions for how to effectively evaluate a program, any standards or required elements of an evaluation and or metrics? So people are familiar with the kind of metrics that OASAS has used within ITMIS. There are standards that have been used for BHO1. They typically have been around retention and outcomes of treatment. We are looking to expand the kinds of metrics that people are collecting and measuring themselves to. So some of the examples that we've heard or that we've talked about is perhaps somebody using a formal assessment. I think Henry mentioned in his some potential assessment forms, and then doing perhaps a re-assessment of that person at a point along the way. So things like that, and there's a lot of tools that we could talk about or that you could explore that have to do with patient satisfaction, perception of care, that includes people's perception of how much progress that they're making along the way, therapeutic alliance, standards are relating to how well somebody is doing with their recovery plan, including toxicology testing and reports of from the patient of how well they're doing. So there's a whole litany of standards, and maybe it lends itself to actually an entire webinar or presentation, and maybe we could work with CASA on that. Will the Part 814 facility requirements be updated? We're talking with facility here at OASAS, and I'm going to defer that question to facility at this point. I don't think there's an anticipation of formally updating or changing the requirements, but they are very aware of what we're trying to accomplish with 820 and working with providers as they bring in capital requests or develop new programming to be able to meet the needs of Part 820. The staffing requirements presented for reintegration in a congregate setting are inconsistent with the most recent regulations. So, but what we're saying is that if somebody was going to transition a program that currently is in a reintegration program and bring in other elements, stabilization and or rehabilitation, that there would be an expectation that the increase of staffing would span the three elements. The final Part 820 regulations did defer back to the Part 819. Does a medical director need to have an ABAM or ASAM certification, or is the Data 2000 waiver sufficient? The definition of a medical director in Part 800 is that the director have an ABAM or ASAM certificate. It's our expectation. We recognize the difficulty in that, so if we're open to hearing, that you're having some difficulty in recruiting, but we would expect that you try to do that, or look to your own organization where there should be somebody who is ASAM or ABAM certified in other parts of your organization that may be able to fit the medical director bill. The stabilization staffing, can we have a psychiatrist who is ASAM or ABAM certified and has a Data 2000 waiver as a medical director, as well as the person to evaluate, treat psych issues, and then have a family practice NP or PA who would address withdrawal, accepts Suboxone? Yeah, that works. And you could also have a psychiatrist who had a psychiatric specialty in addiction. Regarding the staffing required for reintegration, we were told there would be no changes. There are no changes if you're only doing reintegration. So next question. In the first section, number of beds refers to currently number of certified beds or proposed number of beds. So it would be the total proposed number of beds in your application. It probably is good to note your current certification and then the number that you're actually requesting if you're anticipating a change in that. And there's a question about the medical director's MPI there. You're going to have to apply for an MPI program, MPI through Medicaid. We're currently negotiating with them to try to move those applications, even if you are not considered as an 819 and Medicaid eligible. We have had conversations with the Department of Health, and we are working to facilitate that working through the DOH process. And then all of the actual billing follows the OPRA rules, which are published on in both our billing manual for ambulatory services as well as on our web pages for third-party reimbursement. When are the applications due? There is no specific due date. We're taking applications on a rolling basis. There is a anticipation that will be an evolution, as some people are ready to transition right away and others are going to take some time to do that. There will be a final date where we're anticipating that all medically monitored and all Part 819 programs will transition to Part 820. We don't have a hard date on that to report, but OASAS will determine that date, and we'll publish it as soon as that's been decided by the commissioner. We were under the impression that the nursing services were taken out. Yes, that's true. We were, let's see. We submitted our 820 on December 2015. When will we find out the status of the application? Henry?
We're in the process of reviewing applications, and it's about a 2-week process to get back to you. We'll at least send a letter that we received it and then move the process along.
Thanks, Henry. So some employees will not yet be recruited at the time of the application is submitted. How should they be on the qual sheet? I think that you would just list who you were anticipating recruiting by their credential and by their role and job, the job description, what roles and responsibilities you anticipate them having. They ask for the name of the staff. What do you do? I would put that was vacant at this point.
Yeah, that'll work.
Our insurance company is setting clinical guidelines as well so that we can be asked to, are there any that are available to be for the field review? Yes, I anticipate that insurers, managed care plans will, be establishing some kinds of clinical guidelines as well as outcome measures that they're interested in seeing for their members. And I'm not aware of any that are out yet for review. Actually, we're meeting with plans on performance and metrics and data collection, and that's a question that we can ask and follow up on that. Submit as soon as you're ready to submit. The question being, when should the submission be submitted? We don't have a hard date, but we are accepting applications and beginning to review. Can existing 819 programs reapply for 819 until the reintegration? There are no new applications for 819. I believe that anything that would be new that would come in under 820 at this point. But you could be recertified under 819 during this process. So I think that's your question. If that's not it, you can use the chat function to clarify. When will it end? We don't have a hard date at this point to report, but it's not going to be an unending process. We're going to, kind of evaluate as we move over this next year to see, how many programs have actually made the conversion, and we will have a final date for programs at some point. If you have an RN on all shifts covering all medical, are we required to have an LPN or in addition to the RN? No. If the RN is doing, the LPN's purpose is mostly to monitor, do triage for patients, collect data, collect medical assessment information for the RN, help with self-medication and keeping track of self-medication and observation of medications. If an RN is filling the functions of an LPN, it's not needed in addition. We're a small congregate 2 with 6 beds and apply for reintegration and just saw the staffing profile. How can we afford that? I think that we've covered that. If you are only applying for reintegration, the staffing model stayed the same. Vocational counselor required in stabilization. Henry?
Yes, we're trying to assess people from the very beginning for discharge planning, so that's one of the functions that we're looking for, someone to assess people for employment or voc ed training.
And remember that the staff can be shared.
Regarding required medication-assisted treatment, is each place required to offer all or just selected medications? So the idea here is, in terms of the big vision for WASAP and for, really kind of changing the way that addiction treatment is provided, is that we would expect that all programs would have a menu of all options that they believe that their population could or would benefit from. And so obviously you would have, in order to offer methadone, you have to have a agreement with a methadone program to be able to, as exists right now, how you handle that would be the same. But for other addiction medications, it would be per your medical director. But we would expect that you have the ability to provide a full range of addiction medication. When should the submission be completed? As soon as you're ready to submit it. And, we have been working really closely with CASA on some learning communities. We're just, I think CASA and OASIS are finishing that first round of New York City ones in the near future. We're going to roll out a residential redesign forums and then follow that with learning communities upstate. But we expected that people took good advantage of those learning communities and took time, and that it does take time to really think through. It is, a change of the way that you typically think about treatment, the way that you've typically provided residential care, and so, as you're participating in those learning communities and talking with your staff, I think Henry made that point, or Brenda, early on, that we really want this to be a submission that you've really brought in the ideas of not only your staff, but the people who are residents in your programs. And everybody from the board members all the way to, your current residences and perhaps alumni, to really think through what are the services that were needed by, by individuals. How do you account for this kind of flexibility that we're asking for? It's not something typical that residential programs have, gotten their minds around. That's what we're hearing in the learning communities. It's one of the more difficult kind of concepts. And so take your time. We're under the impression that the nursing, okay, yes, we got that. When will our current 819 end and 820 have to start. Again, we don't have a hard date to share with you today. At this point, there is no, absolute date in which we will stop. We will require that the conversion to 20 has happened. Please define transdisciplinary team, interagency or intra-agency. So that can be both, but what I think Henry's referring to by transdisciplinary, and I'll hand it over to Henry to correct me if I'm wrong, is that it represents multidisciplinary teams. So there are members of the milieu staff, as well as maybe peer recovery staff, medical staff, clinical staff, CASACs, all working together. Henry, anything you'd add to that?
Yeah, I think that as we move to transform the system of care, we've been talking about breaking down these silos for years, and defining your vision needs to include all of the people that work in your facility, and you just spoke to that a couple of minutes ago, and that's the multidisciplinary or transdisciplinary team, that attempts to affect change with that particular participant in treatment.
Thanks, Henry. There is, the only other new question I see here is what's the daily rate for rehab? The rates are published in, for downstate, the rehab daily rate is 163, and for upstate it is 142. Yep. The LPN is not required in reintegration in the new 820. However, if you are going to bring on rehabilitation or stabilization, the staffing pattern that will increase in those levels of care will impact reintegration. Okay, these seem like they're recurring questions. So, okay. So I don't understand how reintegration services are paid for. That is the same way that they've always been paid for: congregate care, await-us, not deficit funding, and personal needs. So all of the same streams, and the clinical services are paid for on an outpatient basis. And if that's a question about nurses, I think we've covered that. Can you talk about your concern about providers who are providing reintegration and rehabilitation and or stabilization about reintegration? Yes. Creeping, yes. So one of the concerns that so while you're making a plan about how all of these beds should be structured, there are obviously multiple ways to consider your program. Brenda talked a little bit about, maybe having some discrete bed kind of spaces versus, allowing each one of the beds to kind of transition with the patient. Obviously, our vision is more toward letting the beds transition with the patient needs, so that it's driven by the clinical need of the person who is in the program, rather than trying to fit people into the program space that you currently have. So what will happen if you do that and you have all three levels of care, stabilization, rehabilitation, and reintegration, you need to be able to move people out of reintegration to avoid having people kind of get bottlenecked into the program and start holding beds and then creeping into your rehabilitation or your stabilization abilities. So that so while you're thinking about this, I think it makes perfect sense clinically to have all three phases in a single program, but you have to think through how you're going to move people who are ready to move out of reintegration into the community, so that they're not, when they're ready, so that they're not taking beds, taking up a bed for a long period of time when they've been ready to move. So thinking about either some scattered site or having agreements with housing programs programs, some ability to be able to move people out quickly. And, you know, that's some of the reasons to do the vocational and the discharge planning right from the very beginning as well, or to consider having your reintegration beds separated in a different program from your stabilization and rehabilitation. Any of those kind of ways of thinking about it would work. Do we have anything there that's different? Reintegration clients are allowed to attend 822 for treatment. The slides are going to be available on the MCTAC website.
Yes, the slides will be available on the MCTAC website.
Thanks, Brenda. How is the state planning to address workforce development, given the expansion of the staffing? So, I mean, that is a truly good question. You know, in the context of transformation in the whole healthcare system, we are anticipating more and more integration of care, you know, from the physical health to SUD. We're very open to trying to impact, you know, greater interest and skill and in working with people who have SUD from the medical and clinical community. So, you know, I know Julia Fesco, you know, works regularly with the schools and with other, you know, with the talent management committee to do that. But we're, you know, if there are specific regions or specific questions that you have or things that you believe what WESAC could do to encourage workforce development, we are definitely open to that. We want this to be successful, and we want to help you to be able to recruit who you need to make this happen. Our organization plans to offer all 3 phases and has several scattered site locations currently. Would nursing staff be expected to visit those locations? No, not necessarily, unless there was a specific need, in which case that could happen possibly from a clinic setting where, you know, and not from the residential setting. Because once you're in reintegration, those clinical services are provided off-site in a clinic setting. So. If an application is rejected, can it be submitted? Yes. When Henry talked about a success-driven application process, that's what we mean, is that we are going to work with every applicant to be successful. Our interest is in making sure that everybody transitions to 820, and we're going to work collaboratively to do that. Must all staffing be in place prior to becoming certified and operating 820? No. It's not. There is a little bit of chicken and egg complexity to making this happen, because obviously the Medicaid dollars won't flow until you are certified, and you won't be able to afford to staff until probably you have access to that. That's why you can talk to your field office about you know, some startup money. That's what the startup money that we've talked about is for, is trying to build up the staff to be able to, but you have to have a clear plan to be able to bring that staff on, and we have to be able to, you know, be sure that you have something like a medical directive for stabilization before we approve it. So recognizing that maybe not all staff will be on, we have put some provisions in to help you to staff up prior to, you know, going 100% live. And, you know, we recognize it's going to be a bit of a stepped kind of a process for you to be able to bill and get a regular cash flow. Can we decrease the current license of integration number of beds and add rehab beds, or are you just asking to add to what we have? So that is, that's a planning question. It's definitely something I think that's come up in the learning communities, is how to transition beds specifically. And either option is potential. If you were to increase your total capacity in the process, facilities would become a part of the review process to ensure that the space was there and that it was meeting the regulatory requirements around facility space. If you were planning to decrease overall beds, and or if you were planning to utilize just the same number of beds in a different way, that would be also allowable and would be a different process. So. Okay, so I think we're getting toward the end of the hour. If there are other questions there that we haven't answered, we will do a Q&A on this and post it.
Yes, correct. So this is Ileana from OASIS. Just to affirm for everybody, we also got some questions about whether or not the recorded presentation will be posted on the MCTAC website. The answer is yes. The PowerPoints will be posted as well, and also we will be going through the remainder of the FAQ questions and being put together an FAQ document. So with that, to the MCTAC staff, is there anything you need to do to close this out formally as far as the web is concerned?
No, we're all set.
No, I think we're just thank everybody for coming, for their patience, and hope that this was really helpful and you completing a successful application. And Henry and I appreciate, along with Jill Patton and Ileana, your participation in this webinar. Good. Okay, thank you.